Yes. So today we are going to start our very first webinar of the South Asian Alliance of Mental Health, South Asian Union of Mental Health. The union was established this year after the Speak Your Mind campaign meeting held in Kenya. So after that only, the our Pakistan team take the initial action to start this kind of alliance. So this consists of five organizations from four countries. From Sri Lanka, it is Kanimage Lanka. From Pakistan, it is Taskeen and TPO Nepal. And from India, Sangat and Marvila Health Initiative. So we are going to start the webinar as we are running out of time. We have only 1.5 hours available for the session. So I'm going to introduce our first session at the beginning, but in the meantime, I will share the links that you can connect to the organizations in your each country, so that if you are not a member or not a partner of these organizations, you can take part with them, join with them for to move on mental health. Dr. Rubina, I think I am pronouncing properly,
That
is a
is correct.
consultant clinical psychologist whose extensive work and experiences as an expert in mental health was recognized when she was appointed a member of the Sindh Mental Health Commission. She has also served as faculty consultant and a professor at various prestigious institutions in Pakistan. She has Institute of Business Administration, Aga Khan University, and National University of Science and Technology. Dr. Rubina's contribution in community mental health and public health is a credit to Pakistan.
Thank you so much for that intro. Just a little bit about myself. Yes, my name is Rubina Kidwai. You pronounce it correctly. I'm speaking from Karachi, Pakistan. A couple of words about me. I was, first of all, can you see, is the presentation up on the screen?
Yes,
Yes? Okay.
yes.
Okay. So I was trained as a clinical psychologist, but as I'm sure a lot of you will agree with me, one cannot work with human suffering and human pain without eventually becoming a social activist. Because we understand that in addition to individual biological factors, so much that comes into play for mental health has to do with society, culture, politics, and the interaction with those systems. So in the long run, I have, even being a clinician, my interest is broader public mental health and community mental health. I grew up and studied in Karachi, went to the US, studied there under almost 14 years, and I've been back since 2002. So in my 18 years of practice and numerous activities within the field of mental health, I have observed some changes. I am going to be sharing my observations with you. And I'd like to make a couple of disclaimers. One is that whatever I'm saying is my own thought, my own lens. This is not hard data, but it is my observations as I've seen changes in our environment, in our country, in our society in terms of mental health. But I acknowledge that there are many other champions of mental health, professionals and non-professionals, whose vision and ideas may not be included here. And the second disclaimer is that I am from the biggest city of Pakistan, Karachi. I'm familiar with what's happening in other big cities, but 2/3 of Pakistan is rural areas. And much of what I'm going to say, unfortunately, doesn't necessarily apply to the rural areas because not much change has happened in terms of mental health in rural areas. And real quick, just want to touch upon SDGs, which all of our countries have respective commitments to the SDGs. And I think we all understand that so many of these goals, you've got poverty, hunger, inequities, unemployment. So many of these are so intimately connected to health and mental health. And we cannot achieve these completely unless we address mental health. And unless we address mental, and unless these are, and if these goals are not achieved completely, they impact health adversely. So these are closely, intimately connected. I have 20 minutes, and there's a lot one could share, but I'm going to sort of just, give you a few ideas about what I've observed in the past 18 so years. And I'm going to touch upon awareness raising, sensitization about mental health services, advocacy, a little bit about regulation legislation, and education and training. So first off, I want to say, from the standpoint where I'm standing, I see that we do, in many ways, have come a long way on the indicators that I'm just going to talk to you about. And yet there's quite a bit of road to go, much work to do. And why do I say that we come a long way? One thing I've noticed in the past 18 years is there has been gradually greater awareness, greater number of people willing to talk about mental health. You know, in 2002, when I came back to Pakistan, I joined an NGO, worked with them 8 years. And every year that NGO would celebrate the World Mental Health Day, which all are familiar with. That's promoted by the World Federation for Mental Health. So the NGO would have camps and seminars and sometimes activities in schools. And then my job was to write up a one-page report and send it to the World Federation for Mental Health. This is what we did. And then when we would have those events, we would invite, you know, many stakeholders, doctors, non-doctors, persons with lived experience, journalists to the event. Somewhere around 2008 and 2009, we started to get regrets because other people were saying, well, we're going to have our own event. In 2011, I went to the US and I called the Office of World Federation for Mental Health and introduced myself. And lo and behold, the person on the other end knew me and knew my name and knew the name of my NGO. And I was bowled over. How is this possible? But because ours was the only report they used to receive from Pakistan all those years. But things have come quite a bit ahead. And if you fast forward now, there are countless universities, hospitals in a lot of different cities that hold a lot of different events to celebrate World Mental Health Day. And for each organization that organizes this, numerous people, students, faculty, or if it's a health setting, a lot of health workers are involved in it, and they hold public events, which invites public attention. And so the idea of mental health and wellness, and whatever theme of the year is, engages people. So there are groups that have gone to schools and have conversations with young children. This year, even the television gave a few minutes to share that it was the World Mental Health Day, and the television we know has millions of viewers in hospitals, universities, had seminars, had flyers. So I think I have seen a positive change in that more people are investing time, energy, and effort to raising awareness about mental health, where 20 years ago, it was taboo to talk about it. It was taboo. It was just, there was so much mysteriousness about it, which I think has lifted somewhat, at least in the cities by now. The other thing I've seen change for the better is that there's greater likelihood of a dialogue and discussion about mental health issues. And I think I see this more in the younger generation. And I think that the presence of many of these social media platforms have really facilitated in groups and forums coming together. So there are forums for domestic violence, there are forums for girls with history of sexual abuse, there are forums for those who self-cut, forum for youth and mental health. And that's where, so it's awareness raising is holding events and people are passive about it, they listen to it. But when you have forums, you actually have dialogue, there's reflection, there's question and answers. Interestingly, throughout the lockdown, I still have a part-time practice, and I get a lot of referrals. Someone saying I'm on such and so, social media platform, and then someone suggested I get help. So the discussion of mental health need and mental health help and being open to this idea, I see this happening more so probably in the more educated class in our society, but I definitely see more of this. The third interesting observation is that more lately we've had in the Pakistan television, we've had several series that have depicted persons with mental illness, some kind of condition, psychiatric condition. So I'm just going to show you a few clips. Here's a play that showed a person with autism spectrum disorder. Here's a play where the female lead had suffered adverse trauma and abuse in her past, and in the show post-traumatic stress. Here's a play in which one of the male leads has dissociative identity disorder. Here's one where one of the female leads has developmental delay. So what happens is television reaches millions of people, and here they depict persons who have the lived experience of mental illness, but whose lives are shown in a broader holistic context of relationships and sadness and disappointments and anger, a person with some kind of condition but having a full life. And I think this kind of a change really makes far-reaching impact in terms of keeping being open about the idea of mental health and mental illness. Moving on to mental health legislation, I think the past few years, in fact, the past 10 years, Pakistan has made a leap in this, just because we were really delayed in moving forward in mental health legislation. When Pakistan came into being, we inherited the Lunacy Act 1912, which you may be familiar, was introduced in the Indian subcontinent in 1912. And many stakeholders had been advocating to repeal this and bring on an updated law for about 35 years. And it wasn't until February 2001 that Lunacy Act was repealed and we got the mental health ordinance. It was during the martial law that ordinance came. However, in 2010, there was a amendment to our constitution where health was no longer a federal issue of federal governance. It became a provincial matter. So the mental health ordinance became null and void. So that time around 2010, really there was no mental health legislation law in Pakistan, and within provinces, interested stakeholders were advocating to make it an act. Sindh took the lead. We got the Sindh Mental Health Act in 2013. Punjab was to follow in 2014. KPK got their act in 2017, and Balochistan just got their mental health act last year. There is, as of now, no mental health law in Islamabad FC area because Islamabad is independent in Gilgit-Baltistan and Azad Jammu Kashmir. This is an important development for us because we all know mental health law is to protect the rights, civic, basic human rights of persons with mental illness. And there have been, for the longest time, a lot of stories about persons being locked up, persons who have no mental health history issues being locked up because of issues of property. Much wrong had been gone, but now, according to the law, all that is against the law, and someone can be punished, someone fined for mistreating someone with mental illness. There's still ways to go. I am a member of the Sindh Mental Health Authority, and there's still ways to go in the sense that we're establishing, passing laws and rules which will make the law implementable. Sort of takes the time through the bureaucratic process, but I believe we're heading in the right direction. Some of the other changes I've seen over the years is, like I said earlier, more people are willing to talk about it. Several media personalities, actors, singers have come forward and talked about the mental health issues. It makes it people, especially younger people, easier to connect with and to say, well, it's okay to talk about it, it's okay to reach out. I've also seen in my own practice and my colleagues' practices, we get more people who are self-referring. So 20 years ago, 18 years ago, we only got referrals from, let's say, a psychiatrist, and a psychiatrist refers someone only when someone wasn't getting better with medicine. People never came for life issues, and even when referred, it was a big taboo. It was a big challenge for someone to actually make that call. But now we get a lot of people just referring themselves and looking for issues, life issues, parenting issues, relationship issues, which tells us that this is preventive work. Someone reaches out for help early on before it turns into a serious mental illness or challenge, and this is more preventive work, and people are beginning to open up. Also, several of our colleagues who work in mental health service settings tell us that one of the biggest source of referral is not a psychiatrist, is not a doctor, is not a school. It's usually patient to patient, client to client, which means that even if there's still stigma about reaching out for help, I think it's relatively less stigma now. But once someone comes for help and gets better, they are likely to bring in other people. And also, interestingly, I'm not sure what the experiences of my counterparts in other countries, I'm sure you'll tell me, but we noted here that people, the more someone is educated, the more stigma they have about being seen getting help. And many times clients from less advantaged groups, less education, once they get help, they have no issue rounding up the whole neighborhood, whoever needs help. So that's an interesting observation we've made here. Some of the other positive changes I see is that there's more task sharing, and if you're all familiar with the WHO triangle, where the top tip is the specialists, psychiatrists, and clinical psychologists, and then that's it. In Pakistan, that was it. But now, in the past few, I'd say about 7 to 8 years, we see more therapists, counselors, community-based counselors, more psych rehab specialists. There's just a couple of organizations that are offering these trainings, but we do see more professionally trained psych rehabs, and also the UNODC program, the United Nations Office for Drug Control, I believe, has trained quite a number of substance abuse specialists. So that's out there too. And like I said earlier, use of digital platform. There are several organizations, private organizations, that have set up online mental health counseling or online counseling or even training services, and those are being used. And I think, as you all may have experienced the same, with the onset of COVID and the lockdown, the whole idea of mental health came right on the forefront right from the beginning. This is the first time, and as soon as the lockdown was announced by the government within, I think, a few weeks also announced setting up of 2 helplines for mental health and emotional support. And also we saw a huge number of clinicians, hospitals, psychology departments, private practitioners offering online services. So you might say, those who were shy before to think that these services can be offered in this way, actually sometimes being forced to do this. But the idea is that the idea of getting help just opened up. And also it makes for greater accessibility, it gives anonymity and privacy, so it was easier for people to access it. One of my colleagues in the beginning was offering, she's from the psychology department in the major university in Karachi, and her team was offering 24/7 services initially to those diagnosed with COVID and to community members. And she told me that her phone was silent most of the day, but around and after 11 p.m., many women would call saying that that was the only time they had to themselves. All day long, they had duties for children and husbands and in-laws and never had time. So if there was anywhere to go, they couldn't have accessed it. So that's one example how, online or digital platform for services has actually, this is one way where people who couldn't have been able to access before were finally able to access this service. So some of the challenges, what do I see? I think one concern is that whatever changes they have been, so I said that there's counselors and therapists and rehab specialists, but all of this revolves around tertiary care. It's all specialist care. And majority of these treatment or care modalities do not include rehabilitation model. So treatment right now is still removing symptoms, removing dis-ease. But the idea of helping someone with a lived experience of mental illness integrate and become a whole self and live their whole life is still lacking. Secondly, we still don't have a model of community-based care. There are a couple of private organizations that have trained lay persons, lay counselors, women from communities who have minimal education, and they've been trained to offer basic counseling, and that has worked. But because these are private organizations, their scope is smaller, and these initiatives need to be taken and adopted by the government at large. There's also no work on promotion of mental health and resilience. So again, the larger public mental health aspect is lacking in a big way. Like I said earlier, most of this progress has taken place in the major cities, leaving a vast number of Pakistanis, 64% in rural areas, that are not tapped in, their needs are not tapped in. Digital platform, which has both contributed in awareness and use, is impacted by the issue that we have limited internet connectivity and services here. Also, many community members don't own smartphones or laptops or computers, so that's the limitation. Also, many females, even if they own a phone, are not allowed to make calls. Their phones are given to them so that someone can call them. So those limitations are that we need to be taken. Major issue that we're seeing in our country, I think, is that even though we have more persons entering the mental health service field, there's no regulation. There's no standards. There's no concept of boundaries of competence as to who should do what. So there's a lot of poorly trained, untrained persons also offering mental health services, which makes for malpractice and quackery. I think that this is an area that in our country, we need to look at seriously. There's also a lot of pseudoscience in the name of mental health services. So I'm going to skip to what I think the way forward is. A couple of ideas that have worked, I think that could be scaled up. I already mentioned the program about training community women as lay counselors. These are women with 10 years of education. They're given about 20 hours of training, and they can do basic counseling, and it is proven in research to help significantly reduce depression and suicidal thinking among the women. I think just like all your countries, Pakistan also depends upon lady health workers in our health system. So we already have an infrastructure, and if we could develop similar kind of mental health providers with community mental health promoters or something to the sort, who can not only reach out in rural areas, but who can also meet the greater need, which is simply for screening and basic listening, which if met, people, some prevention of more serious problems can happen. I'm going to skip here and say I think it's very clear that what we need right now is a mental health plan and policy. We do not have one, but our current government, our current president, in March 2020, just before serious lockdowns and all, had announced that they would come up with a proper mental health plan and policy, because the key learning is change is inevitable. I reported the things that I saw, and things have changed for the better. But change is organic, it's inevitable, it happens. But if we don't harness change, I've also shared with you some of the problems. Some groups are served, many go unserved. There are many poorly trained or ill-trained people in the service sector, mental health service sector, who may end up doing more harm than good. So because change is happening, I think it's important to harness this change by developing a clear, definite mental health plan and policy, so that there are clear programs and strategies under it. And the second thing I think is really important is our teaching programs, our universities, and our teaching hospitals that produce mental health practitioners need to, I'm going to say here, we need to establish programs that produce professionals that meet the needs. So in other words, we need to set up departments for community mental health. We need to set up departments of public mental health. We need public mental health research so that we can see what is exactly needed. And if you're familiar with the concept of academic pipeline, the academia is a pipeline. And people go in, they study something, they come out and they serve the society. And right now there's a disconnect between what's happening in that pipeline, and when they come out, they're not really trained to meet the needs. They're not even trained to see, what the current scenario is. So eventually, I would say, I think the need right now with all these positive changes is to give it shape by having a proper mental health plan and policy, and sticking to it's a 5, 10 year, 20-year policy, so that each new government can just follow into the next thing rather than coming up with their own favorite strategy. And bringing in competence-based teaching learning in the department, so we have less malpractice, more competent, ethical practitioners. So this is what I had for today. I hope this has been helpful. I look forward to your input, and I look forward to hearing from all of you. Thank you.
Thank you, madam. I think it was a very informative presentation. So I want to let you know, people, that this webinar is already live streaming on CanMH Lanka, Taskeen, and TPO Nepal Facebook pages at the moment. So you can ask your friends and colleagues to join in. And now we are moving to Dr. Neil Fernando, Senior Lecturer of the Department of Psychiatry, Faculty of Medicine, General Surgeon, Kothelawala Defense University. Dr. Fernando is one of the senior consultant psychiatrists in Sri Lanka. He is a former Director Mental Health of the Ministry of Health, and also an honorary fellow of Sri Lanka College of Psychiatrists. Actually, Dr. Fernando is the pioneer in community mental health services in Sri Lanka. He was the consultant psychiatrist of the Basic Need Sri Lanka Community Mental Health Development Program from 2002 to 2007. And he also has authored many publications in Sinhala and English, and was one of the technical advisors of the National Guideline for the Establishment and Implementation of Consumer and Care Associations of Persons with Mental Health Disorders in Sri Lanka. It is published by the Directorate of Mental Health in Ministry of Health in 2012. So Dr. Fernando serves as the senior advisor of the Consumer Action Network Mental Health Lanka since its establishment. So, Dr. Neil Fernando, sir, it is over to you now.
Okay, can I start now?
Yes, sir.
Yes. Ivan, greetings from Sri Lanka. The topic given to me is to talk about the mental health in Sri Lanka. I will be using my 40 years experience as a psychiatrist in Sri Lanka. And can you move the second slide, please? The topic specifically deals with two important areas: mental health in Sri Lanka in relation to lessons learned and key challenges. So there have been many lessons that we have learned over the years on the mental health services in Sri Lanka, but I have categorically grouped it into four main areas. Next slide, please. The first lesson that we learned was that our services were more or less centralized, which means it was mainly based in hospitals in the cities, and mental health services were not available to the rural community. So that was one lesson that we have learned, a centralized mental health service. The second lesson was that our services were mainly hospital-based. What I mean by hospital-based is that we give our services only to those who come to hospital as an inpatient or an outpatient. The third lesson that we learned was that our focus was mainly on diseases rather than the patient who had the disease. So it was more disease-focused and disease treatment service that we were giving. And the fourth important lesson was that we delivered our mental health services through mental health professionals on one-to-one basis. And that also severely limited us from reaching the people. So these are the four lessons that we learned, and our effort was actually to overcome these problems. Now, as a result of these comings or these lessons, there were some issues that were common to our mental health services. I have now listed those issues under 6 headings: delaying recognition of mentally ill people, delaying seeking effective treatment by the people, non-availability of treatment services, poor quality of services, whereby what I mean is mainly our services were medically based, pharmacological treatment, and psychological treatment such as counseling and various other forms of psychological therapy was not available to many patients who needed them. Then, of course, the stigma and the discrimination associated with mental health was an issue. And of course, myths and misconceptions. So these were the main issues that we encountered as a result of the mental shortcomings that I have highlighted. Next slide, please. And as a result of these issues, you find that there was one common factor that was affecting us. That was the poor mental health literacy in our society. And as a result of that, it led to a very high treatment gap. Next slide, please. Now, in order to overcome this, there have been some way forward measures that have taken place in Sri Lanka. And I will just highlight some key changes that we have tried to rectify. One was to decentralize the mental health services, from a centralized service to decentralize it. In Sri Lanka, the health services are delivered at 3 levels: primary level, secondary level, and tertiary level. When I joined the mental health services were only available at the tertiary level, that is in big hospitals in cities. But most of our population lives in the rural areas, so the primary health service becomes the most important place to deliver the mental health services. So decentralizing mental health services is one of the challenges that we are still facing. Our services are mainly still in the tertiary and the secondary levels, and we need to actually move it down to the primary level in an island-wide basis. So that is one of the challenges that we are experiencing. Next slide, please. The second shift was actually from a hospital-based care to shift our care to a more community-based care. Now, this we started way back in 2002 with the help of Basic Needs Sri Lanka. And now we are able to actually send mental health professionals to the patient's own homes and deliver the services at home. So home-based services, or what we call domiciliary services, are now being conducted, but it needs to be strengthened. Next slide, please. Instead of looking at only the illness part, it is also important to look at the person as a whole, and especially the person's psychosocial factors, which plays a big role in the person's illness. So a patient-friendly approach is something that is of a challenge that we need to actually overcome, rather than focusing our attention purely on the illness model alone. The next challenge that we have undertaken is the involvement of the community in our delivery of mental health care services. Now, as I said earlier, most of our mental health services are delivered by mental health professionals on a one-to-one basis. But we found out that involving the community can actually be of great help. And we started this program way back in 2002 with the help of the Basic Needs Sri Lanka organization, where the community was involved. And when I say that the community was involved, actually they were partners of our mental health services. We started it in the southern province and we extended it into many provinces, where the community took an active role in the mental health services in their own areas. They were involved in the planning of mental health services. They were involved in implementing the mental health services. They were involved in monitoring the mental health services. And they were also involved in evaluating the mental health services. So in other words, they were actually a partner with the health services in the delivery of mental health services. Next slide, please. So, if I could highlight the development of mental health services over the past 20 years, from 2000 to 2020, I would like to highlight certain important changes in keeping with our policy of mental health services in Sri Lanka. Next slide, please. The first important thing was the development of a mental health policy. Now, Sri Lanka has a mental health policy which has been updated regularly, and that was an important investment in the mental health service field, having a mental health policy. In addition to this policy, there were certain other policies also that were incorporated into the mental health policy. Sri Lanka is one of the few countries which has a suicide prevention policy. My next slide is on that. Yes. Around the year 2000, we had this suicide prevention policy. As you know, Sri Lanka in 1995 had the world's highest suicide rate in the world. And as a result of that, a policy was drawn up on suicide prevention. We also have another policy which is also incorporated in the main health policy, mental health policy, that is the National Policy on Alcohol Control. And we are now working on another important policy or a document, which is the mental health legislation. Now, as you know, the mental health legislation, the Sri Lanka legislation is outdated and needs revision, and the new mental health legislation is almost complete, and now it needs to go through Parliament for it to be made an act in the Parliament. And once we get that, we will have a modern mental health legislation to care for our patients. Next slide, please. Talking about the development of mental health services, the human resources, when I joined as a psychiatrist way back in 1980s, we had only less than 20 psychiatrists for the whole country of 20 million people at that time. But now the numbers have grown up, and now we have about 120 working psychiatrists in the island. And we also have two other categories that are now available. Medical officers who have a diploma in psychiatry, they are designated as medical officer psychiatry, and also medical officers mental health. Now these are the officers who actually now work in the primary care level, offering basic mental health services to the rural population. Next slide, please. Under human resources, there have been also progress in other professionals, mental health professionals, and the important thing is clinical psychologists. We have about 60 clinical psychologists, but most of them are working in the private sector. A few have joined the universities and working in the health sector. But there is a move to incorporate some of these psychologists into our health service as well. Then there have been always programs for nursing officers, and especially all nurses who undergo basic training they have a 6 weeks course in mental health. And also there is a special course for nursing officers, a 6 months course, and also a course for community psychiatric nurses. So those are the new developments over the last 20 years in the nursing field. Coming on to occupational therapist, one of the universities in Sri Lanka is now offering a BSc, that is Bachelor of Science degree for occupational therapists. And so that is a very good step in the right direction. And also we have psychiatric social workers, and one of the social service department training institutions is offering a Bachelor of Science social work degree, and that also has actually helped to improve the human resources. Next slide, please. Development of mental health services. One important area is the child mental health. And now child mental health is recognized as a subspecialty, and we have psychiatrists, especially board certified on child and adolescent psychiatrists. So that's a right step, and we have extended our child mental health services at least to all the tertiary care level institutions. The next area is the forensic psychiatry, forensic mental health. Again, it is now taken as a subspecialty, and we have trained psychiatrists who are now designated as forensic psychiatrists. Next slide, please. One of the important developments over the last 20 years is the establishment of a community mental health program. Now, we have actually extended this as a form of extension of our services from the hospital to the community. So the same team actually looks after the patient while in the hospital as well as in the community. So for that, we have a multidisciplinary team consisting of medical officers, community psychiatric nurses, psychiatric social workers, visiting mentally ill people in their own homes and providing medication as well as psychoeducation, and also looking at their social needs as well. So this is, I think, a very important achievement that we have achieved during the last 20 years. Next slide, please. Another important step in the right direction, which I think is the involvement of non-professionals in the delivery of mental health care, and especially the involvement of consumers, patients, their families, and also volunteers. We started this first with the basic needs involvement, but now it has been extended island-wide, and I believe now we have about 65 consumer organizations island-wide actively involved in looking after and also providing basic mental health care to the community. Next slide, please. And CanMH, which is the Federation of Consumer Organizations, was actually born as a result of this community partnership. And we can be proud that it is actively involved and bringing the consumer or the patient and the family needs into the mental health picture. Lastly, I would also like to inform you that we have a national helpline for mental health, toll-free number 1926, which is available 24 hours. And it is operated by trained nursing personnel at the National Institute of Mental Health, and where they are able to connect callers to either medical or any other psychosocial help that they need are given. So this is operative 24 hours, toll-free, and it is now becoming more and more popular. And more people are using this national helpline for mental health. So that is what I have to actually tell you in this short period of 20 minutes, the development of mental health services, especially over the past 20 years. Thank you for your patient listening.
Thank you, sir. I think we are on time. We are going good for now. So now I am moving to Nepal. Dr. Saroj Prasad Ojha. I think I have pronounced the name properly, sir. He's a professor and head of the Department of Psychiatry and Mental Health at Institutes of Medicine, Tribhuvan University Teaching Hospital. He's a renowned psychiatrist and mental health expert in Nepal. He led number of mental health projects and researchers that contribute significantly on the mental health development. He was one of the principal investigators in recently concluded National Mental Health Survey at Nepal. Dr. Ojha was the Vice President of the Nepal Medical Association. Sir, it's over to you now.
Thank you very much. Namaskar, greetings from Nepal. First of all, thank you very much, the organizer, South Asian Union of Mental Health. And especially thank you very much for organizing webinar, Mental Health in South Asia. From Nepalese perspective, it is not different than the Sri Lankan and the Pakistan perspective. My 20 years experience when I was practicing as a psychiatrist 20 years back, the mental health service in Nepal, and after 20 years, especially after COVID-19, mental health, the concept, the mental health service, and the attitudes of the people towards mental health is different. So my presentation is basically focused on Nepalese context, key achievements for last few years, and also I'm talking about challenges and way forward discussions. I'm working in University Hospital in Kathmandu, and thank you very much, organizer, for giving me this opportunity. Yes, as you know, Nepal in South Asia is a landlocked country. It belongs to low and middle income countries. Our country becomes Federal Democratic Republic recently, and the area is, 147 square kilometer. And our last census was in 2011, almost 9 years back. Population was 26 million. Now it's around 30 million populations. And Nepal has divided into the 7 federal states. And you can see the Human Development Index, Nepal belongs to 147, and life expectancy is around 70 years. Talking about mental health profile, like in other low and middle income countries, you can see the number of beds, 440 inpatient beds only for the mental illness. And you can see the government's is 112 in comparison to private sector, and 1.5 beds per 100,000. And talking about the human resources, when I was practicing my psychiatrist, that times 20 years back, it was around 20. Now it's more than 200 psychiatrists. And there are 31 clinical psychologists, 15 psychiatric nurses, and officially no psychiatric social worker or occupational therapists. And like in other low and middle income countries, the mental health expenditure is less than 3% of the total health budget. Similarly, when we're talking about mental health profiles, there are different stakeholders, NGOs, private sectors and the community psychosocial counselor trained people, more than thousands, and community-based psychosocial workers, around 250 people trained by different stakeholders, especially NGO like TPO Nepal, CMC Nepal. And one of the milestones, National Mental Health Survey Nepal's, just 1 month back, Nepal government's completed the Nepal Mental Health Survey. And I was one of the principal investigator. And this research was done by the Nepal Research Council. And there were around 9,200 adults and 5,888 adolescents across all the 7 states of Nepal. And we use Mini-7 neuropsychiatric interview tool. And if you see the prevalence of mental disorder, 10%, especially talking about the policy makers regarding the mental health budgeting, mental health services, we didn't have any authentic data. But now after this mental health survey, we can say that at least 10% of the Nepalese people are having mental health problems. Among them, roughly 3% are suffering from depressions, 4% are suffering from alcohol use disorder, suicidality is 7.2%, and current suicidal thoughts is 6.5%. As in other low and middle countries, more than 85 to 90% people of Nepalese people with mental health problems are not receiving any treatments. But when we see the policy and provisions for last few years, the Constitution of Nepal, we have a new constitutions, Section 3, Article 35 mentioned that health is the fundamental right people and basic health to be the free of the cost. So this is the principle, this is the policy of Nepal governments. And similarly, we have a Public Health Act 2019, which mentioned that mental health is as the part of basic health care. And we have also the Disability Right Act 2018, which incorporates the psychosocial disability and provision of free treatment and rehabilitations. And of course, we had a national mental health policy in 1996, and which has been reviewed and in the process of adoption by the cabinet that in 2019-2020. And in this new mental health policy also, integration of mental health in the primary health care, prevention, promotion, treatment, and rehabilitation service, as mentioned by our colleagues, speaker by Sri Lankan also. Similarly, we have also basic health service package, treatment of depression, psychosis, epilepsy, and alcohol use disorder and anxiety disorder included to be provided free of cost, especially in the primary health center or district hospital. We have a national, as we have just mentioned, National Mental Health Strategy and Action Plan, which is being developed and to be endorsed soon by the cabinet, especially after having this mental health survey of Nepal. The government is going to develop a new National Mental Health Strategy and Action Plan. When we see the achievement in mental health in Nepal, especially, there are plenty of the packages developed last few years, especially the Nepal government won, and this type of the package developed by the Nepal government with the help of different stakeholders in Nepal. So these are some of the mental health care packages. There are training modules, especially as our Sri Lankan colleagues mentioned about mental health service at primary health centers. So Nepal has also adopted the policy of integrating mental health at primary health centers. So the mental health training for medical officer and health assistants, which is the version of the WHO MS GAP, also developed. And there are also the Nepalese Nepali language psychosocial counseling training modules developed, and all these training modules developed by the government of Nepal, which is one of the Nepal government's priority in mental health in Nepal. Similarly, these are some of the different training modules, especially detection of management and child and adolescents mental health disorder in primary health care center. So these are some of the training modules developed by the Nepal governments and different stakeholders. As already mentioned my previous colleagues, integration of mental health service at the primary care center is very important aspect. and Nepal government has included the especially new generation psychotropic medicines like risperidones, sodium valproate, fluoxetines. So these drugs are available at primary health centers, and so that we can provide mental health service at the doorsteps. When we see the achievements the last few years, EDCD or non-communicable disease and mental health section established at departmental health services. There are improved budget section to provide there are improved budget sanction in different province level to implement a scale of community mental health programs. This is one of the I think the way where we can provide mental health service at the community. Similarly, there are different intersectoral collaboration between governments, agencies, NGO, and stakeholders. And also there are rehabilitation guidelines for chronic mental illness prepared under implementations. Similarly, we have recently completed National Mental Health Survey in Nepal. And especially after COVID-19, Nepal, like in other countries, telepsychiatry is also one of the major way of providing mental health services. So country is developing tele-mental health guidelines, which is in the process of draft form and is going to adopt it soon. Similarly, the suicide helplines established in our different places in Nepal, mental hospital, in my departments, a toll-free number also we have started, especially after COVID-19. The people are talking about suicides. It's increasing in Nepal because of lockdown, something like that. But when we see the pre-COVID state, in Nepal, there are around 16 suicides every day. So during the COVID lockdown periods, there were around 20 suicides, and people think that because of lockdown, because of COVID-19, the suicide rate did increase. So the people and government has starting the helplines like toll-free number also. Also, we have developed a training module for public health manager to implement mental health care package. Similarly, child and adolescents mental health service gradually being scaled up in our country. As you know, the country like Nepal, where the populations under 18 years there are 40% people are under 40 years of age. So child and adolescent mental health services are also gradually in the process of scale up. Also, there are increasing advocacy and awareness program on mental health and the different cluster activation during emergency, especially COVID-19. The different stakeholders are together working with under the umbrella of Ministry of Health and Populations. Talking about challenges in Nepal also, as in Sri Lanka or in Pakistan, one of the most important challenges to me also I found is misconception about mental health problems and stigma associated with the mental health. When I was practicing 20 years back, the misconception was tremendous, but gradually these misconceptions day by day it is decreasing. But especially after earthquake, 5 years back we had a big earthquake, and after the earthquake and after this COVID-19, people, media, the policy makers are aware about mental health problems in Nepal. Similarly, like in other low and middle income countries, scare of mental health human resources is one of the major challenges. And on one hand, and other hands, the people's literacy regarding mental health is also low in our country. Now, another challenge is availability and affordability of the services, especially the drugs, treatments, medicines, which might not available at the primary health center in one hand. Even if it is available, the doctors are not well trained, or the health workers are not trained. If health workers are there, the medicines are there, the people are not aware. People have some kind of stigma. So these are some of the major challenges in Nepal. That is why the treatment gap in Nepal is around 85 to 90%. So according to the WHO mission principle and according to the Nepal government also, the integration of mental health at the primary health center is the key factor. Similarly, lack of suicide registry and suicide prevention strategy at national level is also one of the major challenges. As we know that after the COVID-19, the rate of suicide is increasing. So also the country is going to develop and adopt the national suicide prevention strategy probably. Till now, we don't have any national suicide prevention strategy in our country. The other challenges in our country is interruption in pharmaceutical supply in the chain management, especially the availability of the medicines in the primary care centers, and the trained human resources is another important aspect of the challenges. Another challenge is insufficient recording and reporting of mental illness in the health management information system. This is another important aspect where we need to revise our HMI system. And another important part is unpredictable staff turnover of trained primary healthcare service provider. Not like in Sri Lanka, in Nepal, medical doctors, those who are graduated doctors, and the health assistants, the undergraduate, the health trained human resources. So their postings sometimes when we train them and they are not in the community because of the unpredictable staff turnover. So this is another challenge for us. Besides all these things, as like in other countries, poverty, conflict, displacement, discrimination based on gender-based style, caste, ethnicity, unemployments, migrations, these are some of the risk factors. Especially after COVID-19, the mental health issue is going to be raised. So based on that, during this COVID-19 times, the positive aspect of mental health service in Nepal is the Right Honorable Prime Minister of Nepal, Mr. K.P. Sharma Oli, made a special consultation with a psychiatrist and mental health professional and last month. And this is the first time that our psychiatrist and other mental health professionals discussed with the Prime Minister. And he was really worried about the COVID fear of the people. And he instructed us to deliver kind of the counseling service to the people. So this was, and we have also recommended some of the long-term policy of mental health policy of Nepal. Similarly, the Supreme Court of Nepal issued a directive order against the government to ensure adequate psychosocial counseling service without delay. And another important part is Parliament of Nepal, Women and Social Committee had instructed Ministry of Health and Population to include mental health services at primary level and to develop the national suicide prevention strategy to reduce suicide. So these are something like the cabinet, the governments, the Supreme Court, the parliaments, also they are aware about these facts. So the way forward is, I think we have to develop the technical capacity because we have also the three governments, the union governments, provincial governments, local governments, as mentioned by Sri Lankan colleagues. Most of the services are centralized. So we need to develop the technical capacity of the province level and local governments. Also, we need to technical support to implement the community-based program. And this is one of the way where we can provide mental health service at the community level. We need to encourage the multi-sectorial coordination mechanisms. In Nepal, as we have already discussed, the private sector, the NGO sector, there are different stakeholders, they are very strong. So under the umbrella of Ministry of Health and Population or under the leadership of Nepal governments, if we work together, we can produce a significant result in our country. So we need to revise the HMI system indicators that will tell us the exact problems. We need to develop the referral mechanisms for several mental health issues. And also we need to ensure the regular supply of the medicine. These are some way forwards. So in my conclusions, what I think country like Nepal, where like in other South Asian country or other local low and middle income countries, we need to have a national plan which is necessary to effectively implement. That is very important aspect. Effectively implement the new mental health policy, especially Nepal. We have become the 7 states, we becomes the federal. There are 3 government structures, and there are so many, the people are not aware about the mental health issues, and there are not much trained human resources. So the national plan, we need to have a national plan which should effectively implement the national policy. So I think it is fundamental for the government to take the lead This is the very important aspect in developing the comprehensive multi-sectorial mental health service strategies for the population as a whole. And to me, I think country like Nepal, well, if it is a political agenda, all the political parties, if they are together, I think we can make a big difference. We can bring these differences when our political policymakers, the people, the trained human resources, and all stakeholders, we should have the attitudes. That positive attitude is very important aspect. So if you see if we have that positive attitudes, it makes a big difference. That is why working together we are stronger. Especially in this South Asian forum, we are today discussing our key challenges. We are discussing about our experiences. I have also learned from Sri Lankan presentation or the Pakistan presentations. So I think this type of the webinar and this type of the working together, so we can bring a big difference. So together we can bring a big difference. So I think this type of the webinar and this type of the working together among our country, our neighbor country, or in South Asia, we can make a big difference because the people are there. The people are not getting treatment. The people are not getting because of stigmatization or because of awareness, and the people are not getting treatment because of the policymakers are not giving priority. So I think this is the right times after COVID-19. We need to gather together and we can work. So let us have a positive attitudes among us, among the different stakeholders, among the policymakers, so that we can make a big difference. With this, I would like to conclude my presentation. Once again, thank you very much, organizer, for giving opportunity to share my experience and knowledge. Thank you.
Thank you, sir. I think last session, Mrs. Tanuja Babre, I think I am pronouncing your name properly, Master in Counseling Psychology from Tata Institute of Social Sciences. She has been working in the area of mental health, psychosocial well-being, and technology-assisted counseling. She has worked with clients across the age groups, gender, sexual orientation to offer counseling and psychotherapy services. Mrs. Tanuja Babre, now it's up to you.
Thank you so much. I think first of all, before I begin, I would really like to thank everybody for having us here. I'm here on behalf of iCall, Tata Institute of Social Sciences, and representing the member organizations, Mariwala Health Initiative and Sangat. It's really a pleasure to be sharing the stage with such esteemed speakers from across the continent with such great and diverse experience. I'm sorry that I don't have a presentation for everybody today, but I'm really going to be speaking about mental health in India from a challenge perspective, where I'm going to try and build a context of how big a problem are we looking at. I'm going to talk a little bit about the kind of response which is available, and then I'm going to talk a little bit about future directions. I also would like to just sort of highlight that while I am talking about all of these aspects, I'm going to try and keep my presentation or conversation brief to be able to leave some time for question and answer and discussion as well. So when we look at the problem of mental health in India or mental illness in India, it's of course a very, very vast problem. And what do we really mean by it being a vast problem? So the existing National Mental Health Survey, which is one of the biggest mental health survey which has been done in the country till now, really highlights that there are about 150 million individuals in India who are suffering from some form of mental disorders and are in need of immediate and direct care with regards to their treatment or with regards to their recovery. So of course, this is something which is a huge number within a country like India. And at the same time, we need to focus upon the fact that we're talking about persons who have a diagnosis or who have a diagnosable illness, and we're not highlighting the number which consists of people who may be going through psychosocial distress. At the same time, when we look at certain studies which have sort of been conducted on a national scale, They also highlight that the levels of, or the prevalence of issues such as anxiety, depressions, which are prevalent, which is almost 42.5% of employed individuals face from some kind of anxiety or some kind of depression, which really again translates to about every second person who is employed within the country faces some kind of diagnosable mental health concern. Now, while we are talking about these issues, and the speakers before me have really very well highlighted certain aspects with regards to mental health diagnosis. So when we look at countries, when we look at, or on behalf of India, or when we look at countries within the South Asia, something which is very, very prominent is that problems of living and psychosocial elements associated with people's identities and their life play a very, very significant role with regards to determining what is the kind of mental health status or well-being this person experiences. To highlight certain aspects around these particular issues, global data indicates that about 1 in 3 women face some kind of violence, which is form of physical, sexual, emotional, or verbal violence in India, which is again by research has been linked to higher tendencies in women in form of suicidal ideations, and also higher vulnerability to be then diagnosed by some kind of, or to be then experiencing some kind of mental health symptoms. We are also looking at about 40% of India's population, which consists of adolescents and young people, which is individuals within the group of 15 to 30 years old, and also known as the demographic dividend within the country. However, again, within this group, we look at the issue of suicide, which is very, very prominent and evident, as suicide is the leading cause of death within this group. And globally, India and the youth this particular group within India stands as second and stands at third from the age group of 15 to 30 and 15 to 39 in terms of the global rate of suicides. Here, certain studies which have been conducted again with adolescents also indicate about almost 33% prevalence of non-suicidal self-harm within adolescents and young people within the country. I also want to highlight a little bit in terms of when we are talking about 150 million people who are in need of mental health care services, we also really need to look at the kind of burden it places on families and it places on loved ones and caregivers in terms of caring for the high number of individuals. And then we need to sort of reflect about concerns associated with compassion fatigue, burnout, caregiving distress, and so on, which again thus sort of marginalizes or further places these individuals within a vulnerable space to be facing some kind of mental health distress. So when I'm talking about psychosocial issues, or when I'm talking about problems of living, we also have to consider concerns around employment, violence, identities related to class, caste, gender, sexual orientation, associated with economic status, social roles which are assigned to individuals, and how all of this really plays a role within contributing to how people are experiencing their well-being in India, and at the same time how their help seeking is determined or how their recovery is determined basis the kind of resources that they have access to. Within all of this, I think at present I also bring in the aspect of COVID-19 and how certain vulnerable groups which have emerged within the country, which is looking at currently a vast range of individuals and groups going through high levels of psychosocial distress, be it migrant workers who have lost jobs or who have lost housing and have had to travel back homes in various states within the country, migrating across large distances, or we are looking at healthcare professionals who are burdened by caring for the current COVID-19 pandemic on the front lines, women, whereby there have been documented rise in the rate of domestic violence. So I'm trying to really sort of place this context and highlight the fact that the kind of mental health need that we're looking at in India is extremely diverse, is extremely vast. And at the same time, each group has specific issues with regards to concerns, with regards to presentations, and with regards to their access to support services. So this entire need and the kind of even diagnosed illness that we're talking about translates to really a treatment gap, which is higher than almost 70%. It ranges from 70 to 83% between common and severe mental health care disorders. So what is the kind of response that is available to cater to this kind of a gap that we are looking at? So when we look at the response which is available, again in India, of course, that response is also highly biomedical in nature. But from a budget perspective, almost 1.3% of the total healthcare budget gets allocated to mental health. And if we really sort of divide this into numbers, it translates to availability of 33 paisa in terms of Indian rupees, which is lesser than even 1 US cent per year, which is allocated to one individual out of that 150 million number that I mentioned some time back. So we are really looking at a vast sort of a gap, a limited allocation of resources. And of course, the treatment gap, which is something which is very higher, whereby we have about one psychiatrist, which may be catering to more than 2 lakh people within the country. Of course, services which are available, they're also centered and which are available across the country are mainly routed through the National Mental Health Care Program, and then they're on the District Mental Health Program, which has availability of a psychiatrist, a clinical psychologist, a psychiatric social worker, and a psychiatric nurse, which is again available in different parts of the country, somewhere a little bit more scantily and somewhere in a good space. When we look at the kind of trained psychiatrists which are also available within the country, of course, they're not enough. Interestingly, if we look at the number of Indian psychiatrists in the US or Indian psychiatrists in UK, they're more than the number of Indian psychiatrists available in the country. So this really sort of, I think, is one of the problems that we're looking at, but merely unavailability of service is not the only problem that we have when we are responding to the mental health care gap. It's also problems associated with the low mental health literacy, which acts as a bottleneck in terms of seeking care, in terms of early identification, in terms of treatment compliance, also in terms of follow-up with regards to these treatment plans. Of course, we look at issues of stigma around mental health. We look at the lack of a psychosocial narrative or a lack of a psychosocial perspective, which focuses on individuals' social location, or which focuses on individuals' socio-cultural context, whereas the current existing response really attempts to treat individuals basis the symptoms that they experience. The kind of biomedical response that we're also looking at, also it's something important to look at is the fact that when the treatment or the response is happening through hospitals, it is merely focusing on caring for individuals as a response to that symptom, and it is not focusing on caring for individuals from a perspective of rehabilitation or supporting them for reintegration within their communities, or supporting them to be able to live a fulfilling life regardless of the disability that they may experience. I also want to highlight here that something which is extremely important from India's perspective is also the Mental Health Care Act, which came into place in 2017, which is based on the principles of the UNCRPD. The Mental Health Care Act is something which is very, very crucial and is also a landmark step in the direction of building more holistic mental health care services. Also because the Act approaches the issue of mental health from a social disability point of perspective. It focuses on the rights of patients to be treated, to be cared for in a way that they see fit within their socio-cultural context and their community. It also offers features such as advance directive to determine how they would like to be treated. It also offers features such as nominated representative, which again allow for a more rights-based response to fulfilling their process of recovery and giving them the decision-making right to decide how they wish to be cared for. I also want to now sort of moving a little bit ahead from the state response, highlight the fact that non-governmental organizations in India have been playing a very, very significant role in terms of responding to the issue of mental health. And there are many models that have come in from India, and the two partner organizations which are available, which is MHI is here today and Sangat is here today, who have been associated with multiple innovative programs within the country, which have demonstrated caring for individuals with distress or diagnosed mental disorders within their community. There is enough evidence coming in from India which highlights that lay counselors are are as effective, if not more, as compared to any trained professionals in terms of caring for individuals, in terms of identifying in terms of early identification, or in terms of even responding to issues within the community from a knowledge creation or an awareness creation point of perspective. Here, I would also like to talk a little bit about iCall, which is again an initiative which uses technology, and there are many other such initiatives which are available within the country, which make use of technology to be able to cater to people in psychosocial distress, and not only people who have mental diagnosis of mental disorder. So iCall again was created against this, founded against this backdrop of a dearth of trained mental health professionals, which were trying to cater to individuals from a very sort of a biomedical perspective. So of course, when we look at a canvas like this, seeking mental health support is really like a luxury and not something which is available and accessible for everybody. So iCall is a national level technology assisted service which makes use of telephone, email and chat in order to offer psychosocial professional counseling services to individuals. I also want to highlight that there is another issue of language which is available, which comes into picture when we look at offering services in India. So iCall is a multilingual service with multiple languages which are spoken across regions. It becomes important to be able to offer services in more than one language, of course. And at the same time, it becomes important to offer services which are diversity friendly, which are affirmative of people's identities of caste, class, gender, so sexual orientation, their individual struggles and their individual trajectories as well. iCall also attempts to offer services in an anonymous manner, again to respond to the issue of stigma, and also the services are offered in a confidential manner so that individuals find it safe to reach out to a service and to share what is going on in their mind and to be able to seek professional counseling services. Of course, as I've been highlighting multiple practical aspects which are associated with people's lives, it is also important to sort of talk a little bit about the fact that there is a vast need to connect people to multi-sectoral responses when we are trying to offer a response in terms of mental health. So the issue of poverty is very much an issue of mental health. The issue of unemployment is very much an issue of mental health. The issue of violence is very much an issue of mental health. Now, to sort of sum up and to sort of highlight that certain aspects with regards to the future direction, I think something that we really need to focus on and something that we really need to look at is also the kind of economic cost there is to these existing mental health problems. A lot of studies, again, a lot of statistics also highlight that India is looking at almost an investment of 1.3 trillion rupees for caring for individuals with mental health disorders between 2012 to 2030, which is a huge cost for an economy to invest. So if we are looking at responding, or if we are looking at sort of working in a preventive space for such a large issue, it is important that there are services available. One of the significant services that I also want to highlight is the Ayushman Bharat program, which was initiated by the government of India in 2018, which for the first time ever, mental health is also something which was considered as an important aspect to be focused on in terms of service delivery at a primary healthcare level. The Ayushman Bharat program attempts to offer services through the Health and Wellness Center. And I think wellness being the key word here, because that is something which is definitely a step in the right direction. So when we're looking at catering to people with such diverse needs and with such vast needs, it is really important that we have available programs which are available at scale. There are interventions which are made at a training level, at a knowledge creation level, as well as at a service level. Services which cater to people, not only those who are on the center, but also those who are on the margins. Because again, if there are services which are focusing on individuals who are coming in from marginalized spaces, there is more likelihood that you're able to create a service which not only caters from one perspective, but services which cater everybody who is at the center as well as those who are on the margin. So with this, I'd like to end my conversation, and I'd like to hand the session back over to the moderator. I once again thank you everybody for allowing this opportunity to speak, and on behalf of iCall and on behalf of TISS, very happy to be representing certain inputs from India. Thank you.
Thank you, Madam Tanuja. That I think we have come to the end of the sessions, but our team is hoping that all the resource persons can wait for another 10 minutes if there are questions arising from the participants. So I am going to thank you all the presentators, all the resource persons that who joined today, Dr. Rubina Kidwai from Pakistan, Dr. Saroj Prasad Ojha from Nepal, Dr. Fernando from Sri Lanka, and Ms. Tanuja Babre from India. And also I would like to thank the team from Taskeen, Marvala Health Initiative, and Sangat, and also TPO Nepal for supporting the event, and also Muhammad Ali and Anam for supporting me for moderate this thing. So thank you very much, everyone. So we are waiting for another few minutes that if you have any questions. One question arose from Nera. So I think it is the question is about the strategies taken to overcome or address the substance abuse across South Asia. I would like to invite the any of the panelists to answer this question. It's about substance abuse interventions in the region.
So I can, if you like, I can just offer
Sure.
a few thoughts. As I had mentioned, since we don't have a mental health policy nor a drug substance abuse control policy in Pakistan, although we've had many people, several people being trained by the UNODC, United Nations Office for Drug Control. But when there's no plan or program, people get trained and they sort of go into their individual private setups and set these. There is also no reliable data. So my short answer would be not anything being done notable at the governmental level, but again, the smaller NGOs and smaller private setups that offer treatment, but most of those are detox and not really the overall integrated drug rehab program that should be in place. Thanks.
Any other countries?
I can respond a little bit in terms of, again, not a response at a national level that can be highlighted, but of course there have been extremely innovative responses which are available from different aspects. Like in Maharashtra, which is the region of the country that I come from, there are also issues of high levels of substance use, especially in terms of farmers. But also this is closely linked to issues of farmer suicide, the economic burden which comes into place, considering the failed crops or considering the kind of debts that farmers and their families may have. There are, would also like to highlight some interesting programs which have again proven effective within this particular space. I think something to be kept in mind is also that not only these programs have not only been just those which have been catering to individuals or catering to these issues in silos, but also those which have been sort of focusing on what are the practical needs in terms of debt counseling, in terms of loan waivers, in terms of family counseling, in terms of support from the community to be able to sensitize the community to support that individual's recovery. I think these have been some components which have proven effective with regards to certain programs that I have worked with. And apart from that, of course, I think there is medical response which is available in form of de-addiction centers, in form of outpatient clinics which offer support to individuals in their recovery.
I think Professor Saroj is going to.
Yes, thank you. I think the substance abuse is one of the huge challenge in Nepal, especially the tobacco, nicotine, People do not understand about the tobacco is also the abusable substance, nicotine is the abusable substance, and alcohol on the top of alcohol is another abusable substance. So these are the controlled substance in Nepal, whereas the cannabis, opiates are the illegal. They are illegal, still the illegal. So I think in one hand, the country has to govern all these substance legally and in a controlled manner. Other hand, I think especially these substances are more started when, especially among the adolescent groups, school children. So I think one of the preventive aspect we can think is we need to incorporate the school curriculums to prevent the substance abuse. If they are aware about these facts during their school time, probably the gateway substance they start, especially the smoking, nicotine or in a coffee as caffeine. So these are the gateway substance, and after that they will develop the hard substances. So probably we need to make aware in school curriculums so that the prevention can be at effective. Thank you.
Any more questions? Dr. Neil Fernando, are you going to speak about?
Yeah, regarding now in Sri Lanka, now addiction psychiatry is now again regarded as a subspecialty. And as I told in my presentation, we have a policy on alcohol control, and we have also done well in bringing down the prevalence of smoking, tobacco smoking. But we need to have more a good program for illicit drug use. And at the moment, the College of Psychiatrists, Sri Lankan College of Psychiatrists, are working on a draft policy and program on bringing down the illicit drug problem in Sri Lanka. So that is the present status in Sri Lanka with regard to addiction.
I think, Ali, you have a question here.
Yeah, actually, I had a question for Professor Saroj, if that's okay. Professor Saroj, I noticed that Nepal has excellent legislation when it comes to mental health and public health. So what would your advice be to young mental health advocates on how we can convince our own governments to pass similar legislation?
Yeah, thank you, Ali. Nepal, we don't have the legislation still now. And probably, I think in 2020 or 2021, the government is going to adopt the new national mental health policy. And the mental health policy, one of the policies, the mental health legislations. So probably that will be there. Most important part is, I think to me is the awareness is very important aspects. If we make the people aware, especially the young people aware about the concept of mental health. The people think that mental means some kind of the psychotic, major mental disorder or something like that. But it's not like mental, there is no health without mental health. So if we bring this concept of the importance of the psychology, mental health is so important, no health without mental health. Or mental health is the ability to cope with all kind of the adverse situations, any kind of the stress factors. So these positive aspects of mental health, I think we need to bring the aware among the young people, among the public, and if they are healthy, probably their quality of life, their productivity will be not only good for their family, but also good for the country as a whole. So I think this is where I think we need to bring some changes, we need to bring some movements, awareness programs among these people.
Thank you, Professor Saroj. I think we are running out of time because we have very busy panelists here, so we cannot keep them furthermore. So I think we will meet again in sooner time. I don't know. Our team will discuss. So thank you all the panelists, Dr. Sabeena Kidwai, Dr. Neil Fernando, Dr. Saroj Prasad, and Mrs. Tanuja. So thank you for your valuable time and thank you for joining in. And also thank you every participant. We had nearly 60 participants from the beginning. So time to time we had people from for 3 Facebook pages at SAUMH Lanka, Taskeen and TP Nepal. So, and also my team, Taha Sabri, Ali, Suraj, Anam, Devika, Preeti and Sweta. So thankful to everyone. I think the South Asian Alliance of Mental Health will meet again with this kind of a webinar. So thank you very much for joining. Have a nice time.
Thank you
Thank you.
very much.
Thank you very much.
Thank you very much.